talk would be on femtolaser, arcuate keratotomies and toric IOL surgery by none other than Dr. Ajay Pal, who has been a guru and a mentor to many in Kolkata, including me. Sir, over to you.
Thank you, Swati, for having me in this course. Well, I have no financial instrument disclosure because the instrument that I'll be describing is the one that I'm using for last 5 years. Maybe 5 years hence I'll be using another device. So this is about, I'll be talking about the Catalyst platform where we do the femto for last 5 years. So astigmatism management, we had a talk just now, because moderate to severe astigmatism is highly prevalent, as Dr. Shugato said, in patients with cataract. It can be as high as 40-48%. And what you know, in 2019 market survey, this is American survey, only toric IOL is used only in 33% of cases which are there already, and 49% of cases no surgical attempt was made, even in a place like USA, so even on our own situation. So this, I'll be talking about the Catalyst COS 6.0. You know, this is the new software they have got. It's the advanced astigmatic management to manage astigmatism for easier, faster and more accurate way of dealing with it. So you have got direct entry of preoperative data, and if you have got the Cassini system, it can just go and interpolate that system. It has got a built-in nomogram now. It calculates on the arcuate incisions and parameters and automatically enters them into the treatment planning stage. And you have got the radial laser alignment marks. These are the corneal marks that come with it, which reduces your reliance on intraoperative aerometry for toric IOL alignment. It also gives you an increased operational efficiency. It's got direct entry of pre-op data, onboard nomogram, and import of iris registration from the Cassini, as I said. Now, if you look at this improved intraoperative accuracy, the automatic system with the cyclorotation compensation is very high. It's 2% of less in 94% of the eyes. Now, this is the study by Koch, Wang and Dewey. This was presented in 2020 in ASCRS, and the error that would be get as against the manual measurement was a 4-degree alignment, which with the Catalyst COS, the new Cassini incorporated is 1 degree. We are not using Cassini. We just put the pre-op data from the IOL master, and that's how we got the results. So this is the again study which said that is the arcuate incisions clinically validated within 0.83 plus minus 0.66 of the intended optical zone, and 0.22 plus minus 0.2 in the intended axis, and intended length also is 0.22. So it's reasonably clear. And this is the Donenfeld, the nomogram that is incorporated there. I mean, you had it for the LRIs. This works simply better for the arcuate incisions because the LRIs are, you know, peripheral 10 or 11 millimeter away from the iris periphery, and this is around the 8 mm within the cornea. If you look at it from the center, it's 8 mm. So probably that's why you are attacking somewhere in the mid cornea instead of the peripheral limbus. So that's what these are the incisions length that we are working on. This is the intrastromal, the femtolaser assisted intrastromal arcuate incisions. As you can see, these are what we used to do it to open the anterior end, but then we have stopped doing that because of the various complaints. So now look at this. This is what we are talking about. You can just feed those values here, and if you're looking at that, you can see where I'm putting in the what degree the intrastromal or anterior penetrating. I can put the cylinder that I have just, and that's the intended arcuate incisions that would be there. And again, when you dock it, that's where the docking takes place with the Cassini. You can see the anterior corneal OCT being done, and that's where you can just place it, and it shows the steep axis immediately and at what axis it has to come, and it's this, and this is the intrastromal that will be there, and look at this. This is the 2 cuts that have come intrastromal, and as you go ahead with the surgery, so you can remove it, and at the end of the surgery, and these cases basically what we do up to 1 diopter. If let's say above 1 diopter, definitely we would say that going for toric lenses. Now this is when we are using the toric lens. This is what we are saying. Market outside 0-180 degree. This could be augmented with your smartphone. Yeah. And when putting that LOI, you have got 0-180 degree. The marks are there, and just put it, align it accordingly. And then now this is an example where it shows 169 degree where the lens would be placed, and when we actually, these are the two corneal marks that come, is 169 degree. Now if you correct it, we can check it there, and actually it's coming that the same way. I can remark it just for the sake of checking it, and at the end of the surgery I can align, I can put a bit of ink mark also in that, and if you don't want, you may not put it. The lens can go in and you can align it accordingly. This was a multifocal, toric multifocal, where we are aligning it along the marks that came in the machine. And this is again another showing a 50 degree, and this is the alignment. Look at this, and as we look at the calculator, see that immediately we have got those two incision marks that are supposed to be come for the toric IOL. Now there are newer machines which has come, the Zimmer 8, where the marks are on the rexis margins. There is on the rexis there is a small notch there. So with the Cassini, with the integrator, I suppose with the even the Varian and the Lensex, the same astigmatism work has been done. So where directly can be incorporated with a Varian there. And as you see, this is again the mark, that is very clear mark on the cornea. We can just recheck it, and that's what at the end of the surgery. So the marks, and in case you have a small pupil, I mean expecting a small pupil, you can put a mark also there, and then see at the end of the surgery what we are trying to do is just recheck whether that marks are okay, and that gives us a really good result. And this is again one patient where the pupil has become small, and that's just marked it blue because we expected the pupil would get down by the end of the surgery. Just augment it with a pen mark, and this is just as the pupil came down. Got the just putting it under visco. Normally I would not put it under visco, but this was again, see, you can just go and compare it with the, it just matches. And this is one of the study that we did, the visual outcome with the arcuate keratotomy, the femtosecond laser assisted, and we generally got a consistent, just a residual for the less than 1 diopter 0.33 and 1 to 1.5 0.25. So it does work for the arcuate keratotomy up to 1.5, but generally we prefer it doing below 1. And these are the various studies which have said that the arcuate keratotomy definitely works up to 1 diopter very well. Thank you for your patient hearing.
Thank you, sir. That was beautifully covered. So do we have any questions here? Sir, what is your, what consistency, how long have you followed up these cases, and what is your cutoff? When do you go for toric IOLs? When do you go for arcuate keratotomy?
See, all patients that are there, I mean those who would not go for a toric IOL would not pay for it, when we'd go for either those, the IHANS or EMV, anything above 0.5, I am going for arcuate keratotomy. I would say anybody above 0.75, I would advise the patient to go for toric IOLs, especially again astigmatism, even if I have, but this is an extra tool that I would not have corrected in normally, but since the patient is going for a femtocataract, even if he's going for a normal monofocal lens, anything above 0.5 I correct with the arcuate keratotomy. Above 1 I definitely tell them that, but I have done up to 1.5, and it's, I mean, patient could not afford, or patient has gone in for IHANS or EMV lenses up to 1.5 the arcuate keratotomy. I would have had problem earlier when I did for a 1.7 or 2 diopter patient, the anterior opening patient did have complaints of dry eye, a lot of foreign body. So right now for last year or so I have stopped the anterior opening. I just keep it interstromal, and it absolutely works up to 1 diopter. So 1 to 1.5 it's working. So I have followed up for the recently, but for last 5 years, well, I've been having absolute result.
What about the age of the patient? Does the correction vary with the age of the patient, the corneal rigidity?
Yeah, corneal rigidity in the younger age, probably not over a period of time, because as the eye grows up, astigmatism we know with the corneals, but it's people above 65, 70, well, they are going in for a for a femtocataract, they want early rehabilitation and all, maybe they would not pay that extra. Definitely, this is an extra armament. I never tell the patient that I'm doing a astigmatic correction for you. This is something I would not have done it. But then for all, even for, the multifocals, I mean, I'm using a particular brand which still do not have a toric trifocal, and the other ones do have. For them, even for 0.5, I'm putting an arcuate incision.
Of this arcuate?
See, last 5 years we have been following. Below 1 diopter, absolutely no regression. Between 1 to 1.5, very variable. Above 1.5, you do end up 0.75 and 0.1, but 0.75 and 1, this is what we have been doing regularly. It's absolutely
If you
minimal.
correct 0.7, even there is a regression, some amount. It doesn't matter.
See, after 1 year, patient forgets.
We have never tried to correct the high cylinder here.
Yeah, absolutely.
It is an additional benefit.
Benefit that you are doing. That's
Choosing monofocal lens, not paying extra for the toric. Toric IOL, patient having 0.75, 0.8, 0.9, we do the 8.
See, had we had a choice that with the best of the monofocals, it costs around, if you look at around 6,000 to 7,000, we have always told them that keep it, say 20%, 30%. They have doubled the price for a toric. So that's limiting you. So, those are, they expect that when you give them, you do surgery, I should be seeing distance clearly. For near, most of the people above 40 are used to glasses. चश्मा नहीं मेरे चेहरे में सूट करता है, नहीं करना है, ठीक है. Trifocal is not. But monofocal toric should be made just 20 or 30 because there's no rocket science in that, I suppose. So, but then it's not a premium. We should not call it a premium IOL. We just call it a better mono.
It should be a regular armamentarium.
Dr. Vaishali and Dr. Paul, how are the results with Indian toric? In my hands, I have seen the Indian toric results are very good actually.
I think a lot of people
Very
are
good.
using and they're very good. Of late, I have started even using
And
oral
as
ones.
Dr. Paul said, there is no rocket science, probably.
Yeah.
There's no rocket science. They just have to, but the machine they have to
But
just
again, Indian torics, they have price double, more than double.
more
of
than
their-
double. I mean,
yeah.
they're following these. They're his masters.
Yeah, why should our companies not on? They are milking us out, so our companies will also milk us out.
Thank you. Thank you, sir.
Thank you, sir. So the take-home thing over here should be that we should be well versed with whatever comes our way, because I had a patient who was lawyer to the ruling party of the state and he came to me, I am myopic, I don't want to go for toric. Do me a femto AK. So this is a kind of awareness the patients are having nowadays.
That is a relative of AJOY. So if the patient is asking,
Yeah, so rather than doing research in his own subject, he is now doing research for this. So we need to be
Problem
well
is
versed
their
with this.
children. They are always on the. They may not be. Their children say no. This is available. This is available.
So yeah,